PowerPoint deck. Okay.
Good afternoon, everybody. My name is Vincent Everts. I'm a trend watcher, and I'm talking to Pradeep, the CEO of Solve.care, and he has an announcement to make, basically coming up with an very interesting and very ambitious announcement, an exchange, a medical exchange, where we basically can connect patients and doctors in an international way with all the technology needed in this Corona time. So this is really, this is going to be very interesting. We're going to talk about that. First, I'm going to talk a little bit about the influence which Pradeep thinks of Corona in the healthcare sector, and then we're going into his announcement. So I'm glad everybody's watching, and we're going to have fun looking at that. Pradeep, how are you doing? Where are you currently?
Hello, Vincent. Good to see you again. I am in the Solve.care Ukraine office. I've been here for the last 3 months with my team, shepherding them through this coronavirus period. So
why
it's been well, I chose to stay with the team. First, I didn't want to take the risk of flying 18 hours back home and bringing disease home. And second, I wanted to be close to my team, make sure that during this period of uncertainty, they don't feel like they have their CEO sitting far away from them. So I made the decision to be close, and my wife, as saint as she is, as holy as she is, she said, yes, you're right, you need to be close to them. So we thought it'd be 6 weeks, 8 weeks, and it turned out to be 3 months. So I'm looking forward to going home one of these days and seeing the kids again.
I can imagine. Okay, Solve.care. I know it for a long time, but tell me when you started with Solve.care and what the basic idea is to streamline the whole healthcare business. What role are you playing?
So, Solve.care's mission from the beginning was always to rethink the way we treat the patient in the healthcare delivery cycle, be it from an administrative perspective or clinical perspective or financial perspective. And I have spent literally more than 3 decades in healthcare in different countries as an administrator, as a software IT exec, as a insurance policy exec and insurance exec. And I just do not see us still to this day making enough progress in terms of really moving the patient to the center of the universe. We always talk about how patient is important, but we build all the systems around the bureaucracy and the processes around administration and payment. And the best implementation we've ever done is to build some decision support systems for doctors, but patient is never in the picture. And I am, as a father, as a parent, as a son, I felt like I was redoing the same thing again and again. I was building more and more silos of information and trying to connect them later on and not really achieving anything in terms of real human value. And having spent that much time in healthcare, I decided it was time for somebody to do the unthinkable and really talk about what the patient needs and how are we going to change the model around the patient rather than excluding them and then thinking about them in the last hour. Yeah. So that was a bold mission, but it's very specific. 3 areas, right? I've always said this. We want to give the patient clarity and visibility over their journey when it comes to administration of healthcare. Who can I see? When can I see? Why I can see? How much will I pay? Who will sponsor my visit and cost? What is my care journey? Am I getting the best care? What are my options? How does the best practices stack up against my care protocol? And financial, making a payment, understanding what is my share and why, and who else is going to pay it, insurer, employer, government. Yeah. Independently, you can solve these problems, but to connect them together is a bold mission. And I felt that if I'm going to make a difference in humanity in terms of the real contribution of having spent decades in healthcare, I felt this was a time to say, okay, enough. We must stop talking and start doing. And then I was lucky enough to have the technological skills and team around me that actually understands the vision and can productize it.
Yeah, and just be clear, you don't replace all the healthcare systems into one your own. You try to connect in a smart way with patients, with doctors, and with financial reimbursement systems. You try to be a glue to make it a little bit less bureaucratic. Okay, so there's a couple of interviews about that online if people are interested more about Solve.care. How many people work in your company?
About 120.
120.
120. Yes.
And how long have you been? How long is Solve.care? Did Solve.care exist?
So March 17, 2017. So we're just over 3 years now.
Yeah. And what are your biggest clients at the moment?
So it's Boehringer Ingelheim, which is a big pharmaceutical company. We designed and launched the diabetes care network with them. We have Arizona Care Network in the US, which is accountable care organization, a group of 4,000 plus doctors and hundreds of thousands of patients that they serve.
Yeah.
And we have one client, another pharmaceutical company that we have not named publicly yet because of NDAs, that is also launching another care network with us, and a hospital system. So the client base is becoming more diversified.
Yeah. Okay. So that's a little bit about the background of Solve.care. And you have been very busy creating smart networks and connecting all these people, the different players in the industry. And then you thought, hey, this is not enough. We need to do something else. We need to set up an exchange, a global exchange. And was that caused by Corona, or was it accelerated by Corona? Can you tell us about that?
I think it was most certainly accelerated by Corona, but really, end of the day, there were two drivers. One is that as we are launching these chronic disease management networks, we have diabetes care, we have mental health, depression, suicide, epilepsy, schizophrenia, dementia, Alzheimer's. We have now cardiovascular disease management network. These networks are electable, right? You as a patient choose the network you want to join. Our vision has always been the patient chooses. The patient decides, the patient has options, and the patient has access on their fingertips. So we understood that these networks are powerful in their clinical value. Okay, I can save lives and prevent heart attacks for the at-risk patients. But unless in the post-COVID world, unless we can link these chronic disease management networks into actual primary care delivery network, we are going to see a significant disruption in care quality because people aren't going to see the doctor right now. People are afraid to visit the hospital. So they're self-treating, they're self-medicating,
yeah,
or avoiding.
The hospitals, everybody thinks they're very busy, but the hospitals were completely empty. For 80%, the hospitals were empty. The GPs were empty. Everybody was empty, and now everything has to restart. And people now know that hospitals are the most dangerous place to go. And now doctors all over the world are trying to adapt to this new reality, to basically do this kind of stuff, what we're doing today, and to basically share the information. But it's all in one big, gigantic siloed world. So, and then what? So let's talk a little bit about your solution. What is this global? I will put on your slides this global telehealth exchange. What is that?
So it addresses actually a number of very fundamental issues. The first issue it addresses is, as a doctor, I need to be able to practice medicine with a variety of populations, groups of patients. Insurance company A, insurance company B, my self-paying patients, my chronic patients. So I have all these pockets of patients that in the real world, before I went totally online, I was managing through a very complicated bureaucratic processes of eligibility verification, billing, payment with each insurance company, with each group of patients differently. So I had basically multiple practices inside my practice. Now I'm being told suddenly to go online and do all this work I used to do in the context of telehealth. And I have nothing available to me to connect all these disparate patients, and my staff isn't my answer anymore. So we realized that there is a significant problem. Even as there is a race towards telemedicine and practice of telehealth, there is a significant problem from a administrative payment, eligibility, and even finding the doctor's calendar and making appointments, because you're going to basically propagate the physical silos onto into the digital telemedicine. And we understood very early on that Solve.care's value proposition is always to streamline administration, payments, and care management. So we took that problem and said, okay, how does this problem look like in the post-COVID world? And we realized that we really need to put together a doctor-specific fabric that allows every care provider, referring physician, or a specialty care physician, or hospital, and the patient to reach that doctor through this one globally available, controlled, and secure access point. That's what we call the Global Telehealth ID. And that telehealth ID operates on the exchange through which.
Wait. This because this is a thing. You have made up a system to identify a doctor, a global ID. Let me put this. Yeah, I don't want to see the PowerPoint, so I have the same slide here. I have the same slide here. You have made an identification system so the doctor can prove internationally that he is a doctor.
Correct. So our vision is, and what we have built is a doctor applies for a global telehealth ID easily on the exchange, and then they have various different levels of verification or certification, self-submitted, peer-reviewed, third-party verified, and they also can publish to this ID, to this address, their availability, their rates, their constraints on practicing medicine, what type of patient they are accepting, and what time of the day they are accepting, and how they want to get paid. So this becomes the, if you think of the internet days, how did we find websites? Well, we learned about this concept of URLs or website addresses, and you had to enter them in the browser to go to Amazon.com or IBM.com. And that was a new way to find information. Now, in the context of telehealth, we see a global telehealth ID as the QR code they can print on their card. They can attach to their email signature. They can share it with the insurance company. They can share it with their referring physician who wants to send patients to them, or to the referred physician who needs to know who is referring patients to them.
No, but I completely understand that. That's wonderful. If you have some international database where you can verify if somebody is really a doctor, and you can have his agenda and your says, but how are you going to inspire people to do that? Because you're a network. Why would I basically go to you and as a doctor and go through the hassle of proving that I'm a doctor? I mean, for you, you have to figure out if it's true, but I have to be motivated to do this. And I'm nicely in America in my little silo. Why do I want to work internationally? What kind of cases do you have for the doctor to go through that hassle? And why would they do that?
So it's a question of which hassle would you rather have. Today, if you want to practice medicine, you have to submit your credentials or qualifications to every insurance company. You can't just walk up to an insurance company and say, I'm a doctor, send me your patients, right? So I'm doing that. I'm doing that with Medicare or Medicaid and insurance company A, B, C, D, E, F, G. And I'm also doing that with patients who want to come see me walk off into the street. When I had a big office, they could walk in and say, well, yeah, this doctor really has an office. He's got a clinic. He's got assistants. He's wearing a white lab coat. He's a doc. Okay. And I might even find you on Google. But when I am trying to practice medicine online, my credentials are going to be a lot more visible and important for patients to choose me. How do I prove that I'm a cardiovascular surgeon who has 25 years of practice unless my credentials become available to people who want to book with me? And typically, I get my patients from referrals. Either a insurance company will refer their members to me, or a doctor down the street will refer their patients to me, or I'm going to get a referral from the hospital, or I'm going to get a referral from my existing patient. So that whole referral model, you would have to replicate that for every telehealth solution you participate in. Can you imagine the complexity of doing that?
And do you think that you're going to be the hub, which where if they do it in your network, can they basically then prove it in other places in an easy way?
Exactly. The whole idea, this is a global ID that is accessible, it's verifiable, it's encrypted. I publish the access rights to my node. So in that regard, as a physician, I can easily control who can see my node, what data is public, what data is private, and under what conditions they can book an appointment with me. When can they refer patients to me? What do I require when they refer somebody to me? What is my rate? What's my availability? What eligibility you must
know
submit?
that you're a reliable person, that you're a reliable network. How do you prove that Solve.care? Because nobody knows Solve.care, right? I mean, you're very big in the clients which you work with, but on a global national scale, nobody knows the Solve.care. How can you prove that if I have an identity on Solve.care, that is basically that carries some weight? How are you going to work with that? You have blockchain technology, but you have other ways to verify that I'm really me?
Yes. So there are several layers of verification. There is first the identity, the KYC, know your client, which is the basic identity verification of Pradeep is who he says he is physically. Then there is the clinical qualifications, which are called credentials in the US. They're called medical qualifications around the world. which a physician typically submits around where they went to school, how long they practiced medicine, where they did the internship, what was their last continuing medical education course they took. This is an entire clinical profile of a physician. And there are different levels of it. So the expectation or the process that rather we have established is you can get your Global Telehealth ID that allows you to do certain things. You have to submit your qualifications to do other things. You have to get those qualifications peer reviewed to do other things. It's a progressive qualification. You
Okay.
have to submit to a CME data to get even more visibility. So the objective of the Global Telehealth ID is, depending on the country you practice medicine in, that country has very specific qualification rules. And
Okay.
those qualification rules apply to you. And if you haven't met them, you can still publish your availability, but perhaps certain type of appointments you will not be able to make
Okay.
because you haven't proven your certain qualifications. But the point is, you do it once. And
Sure.
once you've done it, it is done by either your peer review, other certified physicians that have already been qualified, they can peer review your calls, or you can pay for it, and we will have a third-party independent qualification agency do that for you. But once you do it, then that becomes a digitally encrypted shareable token that you can send to anybody. And they can use that token to get to your profile and then transact with you without you having to buy any systems, technology, or sign up 20 different places.
Okay.
So
So
we flip
there's
that
other,
model.
this is a very fascinating part, this database. If you can have that trust, and I think you're also using blockchain to basically, that everybody can verify that the information is for real. It's not a database
Exactly.
which you can enter. You have a blockchain verified process to basically give that information. Okay,
Correct.
what's the next step? So we have a whole bunch of doctors internationally which have their agenda, their specifications on there. What is the other? What are the other parts of the solution?
So the other part of the solution is, of course, the consumer or the patient's access to the doctor, their ability to find a doctor, see their calls, see the ability, what the availability is, make an instant appointment, make an instant payment if the physician requires prepayment, which is an option.
Mm-hmm.
Um, and then to be able to invoke a teleconsultation or record sharing, ability to send records and share those, and to ensure that the physician has to do a teleconsultation session. At the end of it, receive referrals, receive prescription, get follow-up care through how are you feeling today cards, and to pay.
Yeah.
So it's a complete solution with the exception that we are allowing for, through a well-defined set of APIs, any telehealth solution that exists that the doctor may already have a preference for, to inject their capability into our platform. They can use all the publicly available digital ID along with the APIs, along with the care card concept that we have pioneered, for them to inject their telemonitoring, teleconsult, telediagnosis capabilities into our platform. So we become the exchange through which all these great innovators who are innovating on telemedicine right now, to be
Mm-hmm.
able to inject that straight into the platform and have immediate access to physicians and patients, which would otherwise be a massive barrier to launch.
Yeah, and so I see this is a telehealth technology platform. This is not one platform. You can basically plug in the platforms which are needed for the particular countries and the particular networks and that kind of stuff. It's not one size fits all. You are flexible in this.
Yes, the notion is that we don't want to we want to enable innovation, and we want to enable people who are focused on how to do better, effective telecare, but we are providing them the complete framework in which they can deliver their service.
Okay, and I can also
Right?
connect that framework to my doctor system or my hospital system or my care system. There's APIs where you connect everywhere. You don't want to replace it. You would just want to make it an easy place to do business. Okay, as a patient, my information, which I basically, just like the doctor can submit information on one spot, I can do that too. How do I do that, and where does the information stay, and who has access to it?
So when I submit records to the physician, I create a cabinet between me and the physician, for which only two parties have access to, me and my physician. And
Mm-hmm.
I have certainly the right to sever that relationship if I want, in which case I can essentially close that cabinet and not have that cabinet be open anymore. But once I submit the data to the physician, the data is now a co-owned data set. But for the physician to send that data to somebody else requires my permission if I haven't already given you that right. So if you are my doctor and you want to refer me to a cardiologist, then you can send my clinical card to the cardiologist. But that card, if it does not have my digital signature behind it, will ask me, Pradeep, Vincent sent your card to cardiologist John Doe. John Doe wants to open your card. Do you permit? And in my Care Wallet, I can touch and say, yes, let John Doe see my records in the cabinet with Vincent, because John Doe is somebody I do want to see. And Vincent told me he's going to be referring me to this doctor. So the control is still in the patient's hand. So what we have done is we have separated the location of data. That's not the control point. The control is in the cryptography. So no matter where the data is sitting, I have the key to it. So you can't open the locker without my key.
Okay, so it's encrypted, and what is the role of blockchain in this phase?
It contains my consent. It actually, blockchain is where the key is made available. So blockchain is the ledger where it says Pradeep has given consent, the card can be opened. Pradeep has revoked the consent, card can no longer be opened.
Okay, all right.
So the consent fabric.
So that is clear. Then if you see, like for a doctor, if we go to payment, that's also a very essential thing. There's a Solve.care, there's a care coin. What role does that play?
So this is, the whole exchange is set up as a to run on the digital token called Solve. So we are using Solve as the token for payment, and it is a requirement that all transactions, all payment value exchange between wallet A and wallet B, patient doctor, employer doctor, insurance doctor, is done in the digital token. That token can either be issued by the insurance company or issued by the employer, or it can be bought by the employee or paid for by the patient, if you will. So that allows us to handle all scenarios. I can be paying the doctor using my own money as a patient. I can be paying the doctor using insurance company's money. In effect, then in that case, the token is a commitment to pay. It's a digital voucher saying, yes, Pradeep can see you, Vincent, and when you're ready to bill us, this voucher is essentially a guarantee of payment. But what we are really trying to do is to eliminate the concept of billing. One of the most painful and frustrating things for a doctor anywhere is to see the patient, then spend a lot of time generating a bill, and then sending the bill to the insurance company to go through adjudication process, and I may get a payment, partial or full, 90 days from now. That is not what we want to sponsor. So our model is payment to the physician is instantaneous, but the payment source can be patient, employer, who redeems that token, against whose bank account I'm redeeming the token, can be the doctor, can be the insurer, the employer, or the patient, or somebody else. But the physician does not go through this rigmarole of, serve, bill, pray, and wait. Right? Yeah. That's not the model we want to change. So we want to fundamentally change the model to it's a real-time payment.
Yeah, and Pradeep, just make sure both doctors and patients and nobody, this is just a thing which is in the background, or is this token, yes. Do I need to know what a token is, or do I need to know what Solve is, or am I just basically working with dollars or euros, or if the doctor is in Europe, he's doing euros, or it's in the background making it work, but it's not something we all have to deal with.
Doctor sets the rate in the currency they want to practice medicine in, right? If I'm living in Vietnam as a physician, or you are practicing medicine in Netherlands, you set the rate. It's your service. You are defining the rate in which you want to be paid. Mm-hmm. The patient pays in their local currency, and there is automatic conversion using the standard conversion service. But token is how we transfer the value. The value transfer from wherever the patient is to wherever the physician is. It is far less friction. It's much easier if it is not done through traditional mechanisms.
Okay.
Give me a second to drop my AirPods. Be right with you.
Yeah. This was also interesting, the GTHE ID, a personal blockchain zip code. This is the ID you were talking about, which you basically make possible. Okay, so that is really clear that is a very important. If this is successful, that is gold. But of course, what do you think the chances are in this siloed world where I mean, if I'm in Holland, and we hardly do anything with Belgium. We hardly do anything with Germany. We did with COVID. Actually, we basically brought patients to Germany because our ICUs were full. But normally these systems are unbelievable, not integrated with each other. Is there a chance that a party can have such a database, which is very handy for everybody if it's there, but which hasn't been coming to fruitful to earth on this moment?
Let me explain why this is fundamentally different. So I obviously was in insurance space as an executive, as an IT executive, in both in many different roles, and
Which
we
was
all
what?
maintain.
Which company did you work for? I know that you worked for during the Obamacare. You worked for the White House and the Obamacare. You helped with that thing. But when you were an insurer, which company was that?
So in the insurance space, I worked with and for Meridian Blue Cross Blue Shield in North Dakota, which is one of the premier insurers in that state.
Hmm.
But before that, I worked with practically every Blue Cross in the country because
Okay.
there were at that point in time over 37 of them, and I think I had direct relationships with over 30 of them in implementing systems for them. So as an outside executive, as an IT exec, working for most of these insurers, United, Cigna, Aetna, they were all at one point or the other either my client for my technology or for the services.
Yeah. So you know how
The
complicated and how difficult it is to
Right. And
accept
same is true for
anything.
Medicare and Medicaid. And then I had some chance to go work in China, and this has been quite an experience. The point is that when I go to the doctor as an insurance company, I tell them that I'm including you in my provider directory based on the application you made for me, but it is my provider directory. You have to pay very close attention to what I'm telling you as a doctor. Vincent, congratulations. You are included in the Blue Cross Blue Shield's provider directory. You are
Sure.
now a certified physician. And
Yeah.
then Aetna calls you and does the same. It's not your directory. You don't control anything. It's what I print, it's what I publish on the website. That is wrong. The idea of this is your address. You control the content. You make the availability of this address worldwide or regional or geographic or patient specific. It's your responsibility to decide how much of this ID is visible outside your country. Maybe you're practicing medicine as a pro bono physician and you want to even allow Nigerian patients to access you. It's your directory. And the blockchain's value here is that we can verify that the content is not modified, that your credentials are accurate because they've been peer reviewed, they can be digitally verified, and you can share them with who you want. And you can make this ID not just a dumb address, but where you can actively receive transactions. You can publish your rates, you can publish your availability, you can publish your qualifications, you can publish your requirements for appointment setting, you can publish referral rules. Now it's an active node, right? It's your address. That's why I call it a zip code.
Yeah.
So in that regard, it's yours. Now I am, as an insurance company, instead of coming to you and saying, I want to include you in my directory, I am far more, as I'm going to realize the value of you having your own verified address, I'm much better linking to that and saying, okay, Vincent, I'll just send you my patient's appointment cards to this address. So by creating a different model where the physician owns the directory, not insurance company A, B, C, D,
And patients,
you
and as a patient, I own my directory. Yeah. So it's really, I'm not dependent on my healthcare provider or my insurance company. I own my
right.
data as a patient, and I own my data as a doctor.
Bingo, right? And when I create a cabinet with you, which means that only two of us have access to this cabinet. And when
Yeah.
somebody else wants to get that access, they need to get my permission. You see, it redefines the patient-provider dynamic. But here is a thing to consider. In the US, many dentists don't accept insurance anymore. They just won't deal with it. Their answer is, listen, Pradeep, you want to get your teeth fixed, you pay me cash, I'll give you a bill, you bill the insurance company. I'm not dealing with them. This is an interesting model, not because there's anything wrong with insurance. Trust me, I have been on the insurance side of the table, and I think there's huge value that risk management brings. But right now, that risk management often is seen as a care prevention techniques. So we need to allow the physician the ability to practice medicine the way they want without painting the insurance company as the enemy, because they're not the enemy. We have all evolved into this very bureaucratic mess that
Yeah.
if we don't start to untangle it, who are we untangling it for? Well, you, the doctor, me, the patient, right?
Okay.
So the whole idea is that I never will say to you, because I have grown up in insurance, that insurance is evil or wrong. They're not. They add a very important value. So is government. So is the large employers. But they need to work in a model where patient provider interaction is more effective, not impeded. And I think if telehealth ID model for a physician-controlled directory that can be global but controlled by the physician in its visibility perimeter will open up healthcare to everyone. Which, why would the doctor not want to use it? Because what's the alternative? Keep doing the current things you do today. Keep repeating yourself over and over again, and let somebody else determine who you can see. So for physicians, it's a very simple value proposition why you should do it. You get to practice medicine with whom you want, when you want, at the price you want, and you get paid immediately. Please tell me what's a better alternative than that today. So that's the model.
Okay.
And it is very fundamentally disruptive, but it will take some education, Vincent. I'm not saying that we launch it and everybody will come running.
Yeah.
But when we educate the physicians, every physician I've talked to and spent the time with has said, this is very disruptive, but this is also fundamentally logical. This is the way
Yeah.
I want to practice medicine.
Well, let's look
So we
at.
think,
So this is the big idea. This is the big idea, and you're launching it. Let's take a little bit, talk a little bit about your launching strategy. This is a big thing. This will take years. This is regional implementation. How are you going to handle that?
so we are launching this certainly we are focused on the top 25 countries where there's a very high, the first thing was telemedicine regulation, right? We need to launch it where telemedicine is allowed, is in many cases actively being seen as the path forward. And that's true for most of the countries, but there are some exceptions where countries are not yet ready for approving telemedicine as a valid source of care model. We are watching them carefully, but they will change their mind inevitably because the need is there. But our goal is to launch it based on certainly the highest cost visit per patient visit. So if you can look at this table we were downloaded from the OECD, and looked at the per capita costs, the US and Switzerland lead the world, almost $10,000 each. Those numbers are dated. I think well over $10,000 per patient per year. But
Yeah.
even at the next 30th, Portugal is almost $2,000 a year. So there is a significant opportunity to focus on these countries. And within that, we are focused on English-speaking countries first, and then launch the other languages over time. So the rollout strategy is take the top 30 countries by per capita income, exclude those who are not telemedicine friendly, which nobody in this list is not telemedicine friendly, and then go ahead and focus on the English speakers and then roll out the rest. But really, the rollout strategy is a referral model. We believe that physicians will refer other physicians to this model, and our community will help us expand it around the world. And the patients who want to see a doctor, so it's a network effect we are trying to create. I know it's an overused term, but in our case, care groups, care circles, and care networks all feed into each other. So this is a referral-based model. It's certainly direct physician outreach. We are preparing direct campaign to physicians around the world, but we also are relying on referral-based system, and we are issuing referral programs in different countries wherever it's legally allowed for people to refer physicians to our exchange. If they sign up, then a percentage of their revenue is given to the referring entity.
Yeah. So this is the go-to market. On the 15th, the physicians can sign up and fully launch in July. When can I sign up as a patient? And
Also in July.
where do you think you will first have the critical mass to basically start?
So we have already talked to a variety of physician groups. They are specialty care groups. We have talked to a group that has a large group of psychiatric care providers. We have talked to a large group representing dermatologists. We have talked to cardiovascular specialty care. So specialty care groups we are already talking to, and there is excitement and interest in that. And so we expect to be having them as the first round of adoption. The primary care physicians we are going through the referral network, as I mentioned earlier to you, and I think those curves will intersect sometime by end of this year. Having said that, this adoption curve is, again, we are focused not on the entire globe at this point, but over the next 18 months, the goal is to open it up to every nation on the planet. The only barrier is localization, which we are doing today. So end of the day, my answer is it's a rolling waves, but we expect significant adoption in 12 months time from now.
Okay, and so that's what do you think of COVID? COVID, is it a bad crisis and you take advantage of it, or how do you look in terms of innovation that these things are possible?
I mean, look, COVID as a impact on humanity, I would not wish that to last one single second longer than it has to. And we certainly, I think this is a crisis of gigantic proportion. It has really shaken our society and our economy. That's not just US, worldwide. And people have lost their lives because of this, and many more will, unfortunately. So I see this as nothing good. But I think it has shaken us out of our accepted mode of doing work in business and care. It has truly exposed the limitations of so many of our societal systems, and nothing less than healthcare has come under tremendous scrutiny to say, are we really doing things the way we should be doing, and can we sustain this? And I don't believe that COVID is a phenomenon that will simply disappear. I think we're going to see waves of it. This is my personal view that it's going to continue to impact us for a period of time. Who anybody's guess how long, but we are going to continue to see waves of this COVID impacting our lives. And that means that we need to be prepared to address this problem, not just for the immediate term, but for the long term. In general, though, I do think the one positive silver lining that has come out of COVID is that it has forced us to focus on the inefficiencies of a highly centralized care delivery model that had become the predominant way to deliver care in the last 30, 40 years. And that is under tremendous reevaluation. And the second good thing that came out of it is that physicians are who were previously highly reluctant to use technology in their care delivery model are now being forced to adopt technology at a speed that you would not have thought possible. So, end of the day, there is an opportunity to make the physician more effective and use their willingness to adopt technology as a vehicle to make their life better and deliver better care. And I have one statement about GTHE that I always tell my team. I want to bring joy back into the physician's life. We got to make practice of medicine less about bureaucracy and paperwork and more about why they became a doctor in the first place. And that went away a long time ago. So what do we have to do to bring this back?
Says the man who has built a lot of the systems which
Yes.
the doctors now have to suffer through. Hey, I have a question from Sam Nozo, who is from Australia. And he wants to know how will the exchange access the patient record? And for example, in Australia, there's My Health Record. Will there be a link between the exchange and the database?
So we are allowing for 3 different ways where the exchange can receive data. So first is the patient submits it through the care wallet, which means that they can scan their documents in the care wallet and submit them directly as images. The second is that the exchange has standard APIs for HL7, FHIR, and standard data format. So we can allow the import of data, which is a request model. The doctor can request data, and the other side has to respond to it, right? So that's a request response or a publish subscribe model, which is very common in healthcare. And the third is physician to physician exchange. Physician can receive my data from another physician that I have delegated the authority to. So if I am if I'm being referred to a specialty care, my primary care physician can easily send the permission card, which gives them access to the same vault that you and I have.
So will there also be a connection? I mean, one of the things which Obamacare had was the blue button that you could basically exchange information. Can this also work with those kinds of systems of exchange?
Absolutely. Blue button is built into the exchange on the patient side. They can download their entire claim history and share it with the doctor if they wish. That is a standard feature of the care wallet on the patient side. Absolutely.
Okay. One more question, because I know you have to go. One thing, Jan van der Meer wants to know, are you coming to Germany?
I think Germany is very much in our target at this point in time, and we are actively looking for partners in Germany to help launch the GTHE there. And that's true for the all first 30 countries I mentioned. Our view is Solve.care will rather grow with partners than to try to do it all alone. As you said, we are big in our space, but we're not big worldwide. So we are very keen to find partners that recognize the value of the GTHE and will bring it to the market in that space.
Okay, just a very simple question from Nicolas. How long will it take to capture 1% of the market? I don't think we're going to answer that. I don't think we're going to answer that question. I mean, let's see. You're going to start. I know you have to run because you have another bunch of other interviews, Pradeep. Thank you very much for your time, and quite a small, big project, big idea which you launched. I know you've been working on this mission of yours that you wanted to make it easier and more pleasant for a physician to work and for patients to find the physician, because these systems are not pleasant at the moment for nobody. But this is I think you took good care of a bad crisis to do something positive with it. So good luck with your launch. And we'll get back to that. We'll check in. I'll check in with you in a month or two to see how is it going. Thanks very much for your time.
Always a pleasure, Vincent. Thank you.